Barrett's esophagus may lead to esophageal cancer. The development of esophageal cancer due to Barrett's esophagus can be prevented as well as early detected and managed with a good outcome. So let's discuss about Barrett's esophagus and do this. First, let's see the anatomy. Anatomically, there is esophagus here and the stomach here, and between the two there is a Z-line, which is a squamo-columnar junction formed by juxtaposition of squamous and columnar epithelium, and there is a gastroesophageal junction, which is an imaginary line at which the esophagus in the center stomach begins. Barrett's esophagus is metaplasia of stratified squamous to columnar epithelium. Here are the epithelial cells. Based on their shape, they can be squamous, it can be cuboidal, or columnar. And simple means it's formed by a single layer of cells, and stratified means the epithelium is formed by multiple layers of cells. And the metaplasia is a replacement of one differentiated cell to another differentiated cell. The prevalence of Barrett's esophagus usually the middle-aged and older adults, and the mean age at diagnosis is 55 years, and it's uncommon in children and 2 to 3-fold more common in men than in women. The risk factors for Barrett's esophagus include obesity, gastroesophageal reflux disease, family history of Barrett's esophagus, and smoking. Clinical features of Barrett's esophagus include the specialized interstitial columnar metaplasia. Typical Barrett's esophagus cause no symptom by itself. And most patients found to have Barrett's esophagus are seen initially for symptoms of associated gastroesophageal reflux disease such as heartburn or regurgitation. And also patients with complications including ulceration or stricture may present with dysphagia, odynophagia, and bleeding. Also, patients with long segment Barrett's esophagus frequently have prominent gastroesophageal reflex disease like heartburn and regurgitation. Short segment Barrett's esophagus is not associated with gastroesophageal reflex disease symptoms. So, as we said earlier, Barrett's esophagus is a risk factor for adenocarcinoma. So, whom to screen for Barrett's esophagus? Patients with multiple risk factors for adenocarcinoma should be screened. And the risk factors for adenocarcinoma include hiatal hernia, age above 50, male sex, chronic gastroesophageal reflux disease, white individuals, central obesity, cigarette smoking, confirmed history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. In patients with erosive esophagitis found on initial examination, we perform repeat endoscopy after 3 months course of acid suppression to exclude the presence of Barrett's esophagus. In patients with a negative screening upper endoscopy for Barrett's esophagus, a routine follow-up upper endoscopy for screening for Barrett's esophagus is not indicated. The diagnosis criteria for Barrett's esophagus diagnosis, the criteria varies in different countries. In the United States, the diagnosis of Barrett's esophagus requires both of the following to be present. The first is columnar epithelium lining 1 cm or more of the distal esophagus, and histologic examination of biopsy specimens from that columnar epithelium must reveal interstitial metaplasia characterized with goblet cells. It can be long segment when it is 3 or more centimeters in length, short segment when it is less than 3 centimeters. The management of Barrett's esophagus include all patients, either they are symptomatic or not, should be on proton pump inhibitors, and those without dysplasia need surveillance esophagogastroduodenoscopy every 3 to 5 years. Those with low-grade dysplasia need esophagogastroduodenoscopy every 12 months with possible endoscopic eradication. and those with high-grade dysplasia needs endoscopic eradication and chemoprophylaxis. If you get any useful information, please subscribe and like. Thank you.